everyone, and welcome to the second lecture in our Wolfson Clinical Seminar series. Just as you probably know, the seminar series runs twice a year and it's aimed at practitioners working in the field of young people's mental health. So I'm Olga Eyre, and I'm a clinical research fellow at the Wolfson Centre for Young People's Mental Health. And today we're pleased to welcome Professor Helen Minnis, who's a professor in child and adolescent psychiatry at the University of Glasgow. And she's going to talk to us today about which came first, the chicken or the egg. Before we start, I just want to let you know that the seminar today is going to last about an hour, and we're aiming for the talk to be around 40 minutes, followed by 20 minutes for questions and discussion. You can post questions via the Q&A box, and you can do that during or after the talk. If you post things during the talk, for example, if you want anything clarifying or anything like that, then we can answer some of those as we go along. So yeah, the Q&A box is at the bottom of your Zoom screen. You should be able to see that. And the other thing just to mention is that Professor Minnis is happy for us to circulate the slides to attendees at the end, so you know that while you're listening. Okay, so thanks very much, and over to you now, Professor Minnis, for the talk.
Thank you. Absolutely delighted to be here, and I hear that there are about 80 of you listening. I wish I could see you all, but I'll just imagine. Right, I'm going to share my slides in just a moment. There we go. There we go. So, which came first, the chicken or the egg? And if you're a clinician, you might already guess what I'm alluding to. I'm really alluding to the almost constant conversation that we have in clinical work about, is this trauma that caused this? Or could it be neurodevelopment? Or could it be trauma? Which came first, the chicken or the egg? And I hope you'll, I hope we can really delve into this this afternoon. And I'm going to start with a wee boy who I'm calling Aidan. This is a real case, but I changed the details, although I do actually have permission to discuss this case, but it's just really a way of getting you thinking about this. And it doesn't matter whether you're a clinician or a parent, an educationalist, hopefully this will be meaningful to you. So Aidan is a 13-month-old boy in a foster to adopt placement. He has abnormal body movements and emotional dysregulation. So in other words, when I say emotional dysregulation, what I mean by that is that he boils over. Temper tantrums, meltdowns, whatever you want to call them, frequently. And the paediatrician referred Aidan to psychiatry because she thought this is probably trauma related. So just a little bit of background about Aidan. So Aidan's mother had used opiates while she was pregnant, but people were pretty clear, and there were reports from herself, from her partner, from the GP, from social work, that she hadn't used alcohol. So I guess one of the first things that went through my mind, and was obviously going through the paediatrician's mind, was, are Aidan's symptoms related to his mother taking prenatal opiates? Just going to pause for a moment and let you think about that. If you're in the room with one of your colleagues, maybe chat about it. But do you think that this is likely to be an opiate, a prenatal opiate related problem, these abnormal movements? I honestly wasn't sure. So I went and did a little bit of literature searching, good old Google Scholar. And I was amazed, actually, there's not a huge amount of literature on this when you compare that with the amount of literature that there is on prenatal alcohol misuse. But this was a paper, a 2016 paper, and there have been more recent ones saying similar things, that the potential effects of opiate exposure on the developing infant brain are unknown. And actually, before I even go on, this is based on, although there's not a lot of research, there are some really big population studies. So, I mean, really weighing it all up, I don't think there's great evidence that prenatal opiates are likely to have caused these abnormal movements. I couldn't see any evidence in the literature for that, but maybe the dysregulation. So when Aidan was born, he had mild neonatal abstinence syndrome, which means that he was kind of jittery, but he was actually discharged after a day, so this wasn't thought to be particularly severe. So I mean, I think we can't rule that out, but I don't think there's good evidence that the dysregulation is caused by that. What about the abnormal movements? I was very worried about these movements. They were actually really quite extreme. Aidan was literally kind of bending forward in his stroller. And when it happened, it was so extreme that people, you know, if they were out in a shopping centre, people would be like, "What's wrong with that baby?" And I wanted to exclude epilepsy. I just wasn't sure. And the kind of epilepsy that I was thinking about was a very severe form of epilepsy, which can actually lead to really very severe learning disability when it's untreated. So I thought we need to exclude this. So I referred Aidan urgently back to the paediatrician and said, "Look, can we please exclude epilepsy?" So they did 24-hour inpatient monitoring, and I'm absolutely delighted. We were all very relieved to say that this was definitely not epilepsy. So again, the paediatrician said, "Well, it must be trauma related." I'm going to just pause for a minute and let you have a wee think. And I'm not expecting you necessarily to come up with the answer because I don't think we know for definite. So let's just go through how likely this is to have been trauma related. Well, Aidan was actually placed in this same foster to adopt placement from day one. So he was literally discharged after 24 hours to these foster carers. Foster carers are very lucky. They've got lots of support. One of the parents' own parents are living close and they're really supportive. They've got a great relationship. They both work part-time. There was no evidence that Aidan had ever been traumatized, other than obviously from being bathed in prenatal opioids. So I then actually contacted a movement specialist at Great Ormond Street because I was really stumped. So if you didn't come up with the answer, don't feel bad because neither had I. That was such a reassuring consultation. We were able to share videos of Aidan's abnormal movements. And the movement specialist basically said, this is a stereotypy. In other words, a repetitive or even ritualistic movement, which is often stress-related. And what they said was, look, these often disappear by school age. We've had children in this movement clinic with really extreme stereotypies and they just go away. They said, it doesn't always go away. And if it doesn't go away, it might, you know, we just have to wait and see. But the great thing was I was able to reassure the foster carers that this was nothing serious. And that really helped actually, because when they were out in shops and people said, what's wrong with that baby? They could say, don't worry. It's just a stereotypy and it's fine. Don't need to worry about it. And then other people would stop worrying. They could relax. And then actually that in itself helped Aidan. But the dysregulation, it became clear, was actually the biggest real problem for the family. That was what was really causing them a lot of difficulty. And I mean, it was classic office trashing, you know. Aidan was the kind of wee boy that would come in and start climbing the curtains. He was an absolutely lovely wee person, but you could tell that he was one of these wee boys who, when things were a bit stressful or things changed, he was just knocked 100 in less than 30 seconds. So let's just focus on Aidan's parents for a moment. They just adored Aidan. I mean, you could tell they were so loving. They found him really funny, really engaged, really loving. And they were planning to adopt him. They had claimed this wee boy. But Aidan was much better regulated when one of the parents could really focus on him. So it was lucky that they were both working part-time, because he needed somebody really attending to him very closely all the time and really keeping him on task so that he wouldn't just go off. And that was exhausting even for them, even in their very, very well supported circumstances. And one of the things that we kind of started to reflect, I was seeing them maybe just every 3 months or so, just checking in, because they were doing a fantastic job. They didn't need anything particularly active other than just reassurance that what they were doing, you know, staying consistent, that kind of thing was what was needed. But we really started to reflect on what it must have been like for Aidan's birth parents. So Aidan's birth parents both had addiction problems. They both had experience of trauma themselves. They hadn't had good experiences of supportive parenting themselves. And they were living in poverty. And we were just thinking, oh my goodness, what would bringing up a child like Aidan have been like for parents in those kinds of circumstances, when well-resourced parents in all sorts of ways were so exhausted, and they were going for night after night with broken sleep. So this is something that I've become more and more kind of focused on in the last few years, because I do think that in child and adolescent mental health, I don't know, I feel as if we've developed a culture where there's often subtle parent blaming. Sometimes it's not subtle, I'm afraid to say, where if a child has, particularly if a child has kind of externalizing type of behavior problems, we often imagine that there must be a problem in the parenting. And sometimes it is a problem with the parenting, but I think we also often kind of assume that it was caused by that problem with the parenting, when actually, I think when you meet a little boy like Aidan, you realise that you probably would have to be quite saintly not to kind of lose it sometimes, not to get dysregulated yourself, because it's very, very difficult, especially when you're not had a lot of sleep. So I want to just touch for a moment on something that used to be a hypothesis. It used to be called the differential susceptibility hypothesis. But actually now it's been demonstrated to be the case. So differential susceptibility, it's a shame it's so many syllables, but all it means is that humans differ. In fact, all animals differ in the degree to which they're susceptible to the environment. So some babies, and you see this right from birth, from like day one, some babies are quite happy to be handled, they're happy to be changed, they don't really mind if the light is turned on. Other babies are very sensitive to the environment. They don't like changes in light and darkness, they don't like loud noises, they don't like to be changed, they don't like to be taken out of the bath. Often those types of babies are find it quite hard to fit into biological rhythms. They maybe don't, they're not necessarily particularly good at sleeping when it's time to sleep, and being awake when it's convenient for parents to be awake. So there was an old study that's been very, very influential, and I think rightly so. It was the New York longitudinal study. I think it started in the 70s. It might even have been the late 60s, but Stella Chess and Thomas, they interviewed parents about their neonates. So in the first few weeks after birth, about temperamental features, things like, you know, were they sensitive to the environment? What were their activity levels like? Did they have good kind of biological rhythms? Did they know night from day, that kind of thing? And what they found was that certain temperamental traits were really quite stable over the life course. And they described a particular group of infants as difficult. And I think we feel quite uncomfortable about that now because it sounds pejorative, but I feel as if I can say it because I was an absolute classic difficult baby. If I've got time, I might even tell you the hilarious story that my parents used to tell about me. We'll see if we've got time at the end. But my daughter, I've got two kids. My daughter, who's now 26, she was also difficult in the sense of she didn't like to be put down. I was very lucky because my friend from Zimbabwe showed me how to put Ellie on my back so that I could see her, we could have eye contact, but she was also sharing my world, and she was basically being stimulated while I was getting on with adult things. Anyway, children who are more sensitive to the environment are very interesting. And I've used this metaphor. You might have heard the metaphor orchids and dandelions, but orchids and dandelions being used to describe sort of more sensitive children versus less sensitive children is not that great, because actually orchids and dandelions are both very robust. So I use the metaphor diamonds and gold coins, because diamonds and gold coins are both clearly very precious. But as you know, diamonds are really not very susceptible to being harmed. Gold coins can become tarnished if they're handled a lot. So this is the differential susceptibility model, and it's been demonstrated now in many ways. But what you've got along this axis is a negative environment to a positive environment, and a positive environment doesn't have to be any better than good enough. It's just an ordinary good enough environment. And this is the child's outcome in terms of behaviours, really. So the diamond type of children, this is a very crude metaphor, but the children who are less susceptible to the environment, their behaviour, especially negative behaviours, are not going to be much different in a negative and a positive environment. What's really interesting about these sensitive children is that they're very sensitive to a negative environment, but they're also very sensitive to the advantages of a positive environment, even just a good enough environment. And so children who are difficult in the early weeks and months, by the time they get to middle childhood, tend to be doing better in terms of the behavioural outcomes compared to the general population, which I think is absolutely fascinating. It's very important for children who've experienced adversity, because these are the children who can really thrive if they're in a positive, good enough environment. I think my daughter's a really good example, not that she experienced adversity. We were like Aidan's family, very lucky, very well supported. But she was really, you know, we were sleepless with our daughter in a way that we weren't with our son. And she grew into a very kind of, we would say, feisty toddler. She used to really like to argue. And now she's working in an environment that's very tough, and she's absolutely thriving. So that kind of, you know, you're not messing with me, has become a very, very positive feature in her 20s. So let's just focus for a moment on what is positive parenting. And I really like this. This is just something that I got off Google Images, but this is an exhausted mum. She's just saying, what a day. We didn't get round to playing with that new toy. So she's kind of guilt tripping herself. She didn't get the washing done. And her wee baby's in yesterday's clothes. In fact, she's thinking, when did I last buy new clothes or brush my hair? I'm a state. So she's really guilt tripping herself. She's absolutely shattered. But look, they're snuggling. They're snuggling together despite all of that. So she's an absolutely first-class mother. She deserves a medal. She's got through the day. They're snuggling together. This is great parenting. Good enough parenting is great parenting. And, you know, all of us who've had children who are not the kind of children that immediately sleep through the night, we've all experienced this. Perfect parenting doesn't exist. And actually, if it did, the child would never learn to manage stress, or that adults are separate beings with their own mental states. And I really learned this when I was a higher trainee in child psychiatry. I had a little one. I had an 18-month-old. She was maybe 2 at that time, and I was about to go to a conference, and it was an attachment researcher called David Howe. And as I was running for my train, my wee one was going, "Mum!" And I was feeling absolutely terrible, because it's like researching attachment, and there's me running away, and she's reaching out to be picked up, she's not getting picked up, and I was guilt tripping myself. And then David Howe said I bet there's people in the audience that are guilt tripping themselves about not being a sensitive enough parent. And he said, what I want to do is I want to paint you a scenario. So I'm going to do that for you now. He said, you know, you're cooking chips and your washing machine floods. And at that moment, your 2-year-old comes up and goes, Mummy, I did a picture. And you go, you make your child safe in not a very regulated way. You run around, you make the kitchen safe. And then afterwards, if you're a sensitive parent, you go up and you say, listen, honey, I'm so sorry. Mummy was really, really stressed. And your 2-year-old's probably not understanding the words, but what they're getting a sense of is they're getting delayed soothing, repair, relationship repair. And gradually, over time, those intermittent episodes will help the child understand that mummy also has mental states and that there's a relationship with stress. And if they never had that, they would never understand their own thought processes and other people's mental states and all of that. That was a big relief to me. So I really want to move you on to the idea that stress is not always a bad thing. The adaptive calibration model of stress responsivity. I love this paper. This came out in 2011 and it really meant a lot to me. This is a quote from that paper. Children have evolved to respond in biologically adaptive ways to harsh and unsupportive family environments, not just to loving and supportive ones. It's quite a mind-blowing statement. So in other words, positive or good enough environments ordinarily have some harsh or unsupportive aspects. And even when children are actually abused and neglected, their physiologies are actually adapted to coping with that in different ways, for better or for worse. But in ordinary life, this is a wee baby being soothed by her dad, very normal. And this is an elderly woman who's on her own, soothing herself in her summer house, Norwegian. And essentially, when we go through life, we learn to move from this to this through a process of, bad things happen. So we'll move into fight, flight, or freeze. We have a car accident, our boss shouts at us, something bad happens. And then we'll go back to relaxation and restitution. And remember, babies, our parents help us with that if all is going well. That keeps happening over and over through life. And eventually that allows us to develop a healthy stress response system that's robust to challenges. But what happens if either you're a very, very sensitive child and bad things happen and you get stuck in the red zone, or you're a less sensitive child who's so badly abused and neglected that you get stuck in the red zone that you become continuously over-aroused, traumatized. So you'll all have heard about this idea of adverse childhood experiences. Very briefly, Felitti and co, this was more than 20 years ago now, they did a study where they asked adults about their early childhood experiences. And they asked about abuse and neglect. And they also asked about what they called household dysfunction. Some of these household dysfunctions are very common, like divorce. So it wasn't about individual so-called dysfunctions. It was about the cumulative effect of these. And what they found was that there were dose-response relationships between the number of adversities and risk of negative outcomes. And this one on the left is very well known, that if you've got an experience of more adversities in childhood, you're at a higher risk of experiencing depression in adult life. And if you've got even more adversities, that you're at higher risk of heart disease. So at a population level, the bigger the load, the bigger the risk. But this is where it gets really interesting. Not all children who've had a big load of ACEs actually have problems. And I found this when I was doing a study with children in foster care. We were recruiting children under the age of 5 coming into foster care, and we realised when we looked at the data, the first 100 children, half of those children have a diagnosed mental health problem. And that's really high. But of course, hidden within that is that half of those children who've all experienced severe abuse and neglect, half of them don't have a mental health problem. Why? What else is going on? So back in 2013, I wrote a paper where I described what I called maltreatment-associated psychiatric problems. I really put it out there for people to think about, because I had noticed clinically that even though many people who've been abused and neglected don't develop psychiatric problems, if they do develop psychiatric problems, they seem to be really complex. And I wondered if it was just that people were sending me the more complex patients. But I thought, we need to test this, because honestly, I was amazed that some children just seem to have lots and lots of different overlapping problems. And the complexity often seemed to be neurodevelopmental. So children who've been abused and neglected seem to often have overlapping problems of things like ADHD, autism, intellectual disability, tic disorders. And particularly tic disorders intrigued me, because I thought, I can't see how tic disorders would be caused by maltreatment. But we do know that overlap in neurodevelopment is the norm. That's really quite accepted now, that complexity is normal. So if a child has ADHD, you should be looking out for autism traits, because it's not uncommon for them to have both. And we also know very well now that these things tend to run in families. So if you've got a child with ADHD, you might have an auntie with Tourette's or an uncle with autism. So I guess that raised a question in my mind. Could this neurodevelopmental complexity be what underpins the complexity in maltreatment-associated psychiatric problems? So we looked at that. Now, before I move on to the study that we looked at that, I just wanted to mention there's a lot of debate about the term developmental trauma disorder and whether that's, it's not in the psychiatric classification systems, but it's often used by clinicians to describe children with these complex overlapping difficulties, psychiatric difficulties in the context of abuse and neglect. And what I would say is that I prefer the term maltreatment-associated psychiatric problems, because it just reminds me that not all of these parts are necessarily caused by trauma. But I don't have strong feelings. I'm not going to say to someone, if someone refers me a child with developmental trauma disorder, I know what they're talking about. Anyway, on to our study. So essentially, I was interested in using the child and adolescent twin study of Sweden, because it's big, it's huge, it's like 13,000 twins. We looked at them at age 9. And we asked about symptoms of, when I say we asked about, the CAT study had already asked about symptoms of ADHD, autism, tic disorders, and learning disability. And we asked the question, are the abused and neglected children, so 13,000 twins, a few thousand actually had experiences of abuse and neglect. So we wanted to ask whether these children were more likely to have multiple neurodevelopmental problems, and the answer was yes. But the degree to which the answer was yes was a surprise even to me. So we found that if you think about those 4 symptom clusters, there was a few hundred children in that big population who had symptoms, and 3 out of the 4 could be those 3 or those 3, or it didn't matter which 3. But those children were nearly 10 times as likely to have experienced abuse and neglect. So much bigger effect than, I wasn't imagining this. There's a really loud noise outside my window. I hope you can't hear it.
No, it's okay, Helen.
Oh, that's good. It sounds.
Yeah, it's not picking it up, don't worry.
I've like 3 flights up. I'm thinking, is it a helicopter? Anyway, it stopped anyway. So really, this is the question. It's just a pictorial depiction of the question. Is child maltreatment, does it cause this increased neurodevelopmental load? Because this was a twin study, we could ask about causality, and I'm not going to go into the methodology of a twin study because I'll tell you in a minute, but there's ways you can find that out. The question was, is this neurodevelopmental complexity caused by the maltreatment? The answer was no. It's a very resounding no. What that twin study showed was that there were additional genetic factors leading to both the abuse and neglect and to the neurodevelopmental complexity. And it was actually quite funny because we were on Skype back in the day. We used to use Skype with our Swedish colleagues, and my colleague Ruchika Gajwani, who was the other clinician in the group, we were both in Scotland but in different rooms. And I looked at Ruchika when we got the behavioural genetic findings, and I noticed her, she was like this. And then I realised that so was I, because we were really confused by this. And we can't prove the reason for this in this particular study design. But me and Ruchika went away for a long weekend, and we came back and we thought, well, maybe it's this. Could this be neurodevelopmental disorders running in the family? So are these additional genetic factors, heritable factors like ADHD and autism, in the parents? And if that's the case, is the mixture between the child's neurodevelopmental complexity, the parent's neurodevelopmental complexity, leading to the abuse and neglect? Possibly. I think that the important thing that we should remember is that if a child has neurodevelopmental conditions, the parent might also have neurodevelopmental conditions. They might have problems with impulse control, with learning, problems with language, or with social understanding that could interfere with their ability to look after a tricky child like Aidan, for example. Especially if there are other problems going along as well. If there's poverty, for example, or that parent doesn't have support from their own parents. If you want to think about the methodology, there's a little video that Lisa Dinkler, who's the behavioural geneticist, and myself made when I ask her stupid questions about the methodology. So Aidan is actually now 3. He's a delightful wee boy. He's always on the go. Excellent language and social development, but he has sudden rages with biting. He's got sensory sensitivities. He's very distractible. He's a lot of work, both at home and at nursery, to keep him entertained. He only has his stereotypies at home. His parents are very pleased with his development. He's a warm and loving little boy, but it's very difficult for them to manage his behaviour calmly at times. They are concerned that nursery is about overstimulating. And so for us, it's really important to understand Aidan, to help them understand Aidan's make and model. Does he have a neurodevelopmental condition? And if so, does he have more than one? What kinds of problems does he have? So it's not just about whether you're a Toyota or a Honda. It's whether you've also got wind-up windscreens or electric windscreens, or whether you need unleaded or petrol or diesel. So what's in the box? What kinds of problems does this child have, even if a diagnosis fits? Problems with sensory sensitivities, movement, concentration. What's his strengths? What about his energy and his courage? How can we adapt the environment to make it more suited to his strengths? What lens do you look through? So actually, we have given Aidan a diagnosis. He has Tourette's syndrome and ADHD. And even though he's really young, this has really helped the nursery to understand him, especially to hear that he's also got sensory issues and that the biting might actually be sensory biting. He's also got some obsessive compulsive symptoms. And he's a warm and loving child, popular with his peers, despite the fact that he bites them sometimes. Very supportive and loving parents, a very supportive nursery who now understand that Aidan is as keen to develop positively as they are keen for him to develop positively. And we all wonder whether his birth parents were perhaps less lucky. What would have happened if Aidan's parents hadn't been able to cope? Would he have got stuck in the red zone? So I want to very briefly, before we finish, just mention a little boy called Niall, who I met at the age of 9, also a different name. He was adopted, but he wasn't adopted till the age of 4.5. And from about a month after he was placed, his adoptive parents described him as resisting the relationship. You'd never go to them for comfort or problem solving. He had frequent dissociation. He was compliant in the classroom, but very aggressive. He would actually try and attack children to steal their food. He'd had horrible early abuse and neglect. He also had neonatal abstinence syndrome with no evidence of prenatal alcohol abuse. And although he was found wandering in his pyjamas at the age of 20 months, he wasn't placed in care until the age of 4.5. And that was very traumatic because it was only noticed how neglected he was when his older brother was arrested by the police. And Niall would fulfill criteria for reactive attachment disorder, which is characterised by a failure or minimal seeking and accepting of comfort, emotional withdrawal, hypervigilant or contradictory in emotional responses in the context of abuse and neglect. And eventually he also ended up with a diagnosis of inattentive ADHD. Well, that was quite tough to work out because he was so unable to kind of plug into the people who were trying to assess him. He was a really miserable wee boy. It was very sad. And his family, adoptive family, there was nothing wrong with their parenting. But they were very isolated because people couldn't really see these problems. The adoption was on the verge of breakdown. And let's just think before we finish about, I should say we don't have evidence-based treatments yet for reactive attachment disorder, although we're doing a trial that hopefully might develop an evidence base for this. But until we have that data, what might help? What pragmatic things might help? I do think a really good understanding, a holistic understanding of the child's making model is crucial. Compassionate and respectful support for parents. Don't assume they've caused it. Extra support in school. Psychotherapeutic support may well help. If the child has post-traumatic stress disorder, then we do know what to do. Trauma-focused CBT. We know how to treat anxiety, for example. Medication might help if there's ADHD. There's very little advice for parents as yet for children who've got both problems with trauma-focused symptoms and neurodevelopmental conditions. But this is one example. The literature is starting to emerge. This is a wonderful book by Kate Hunt and Helen Rodwell about autism for adoptive and foster families. And it just talks about all of those nuances and how you tell the difference and does it matter and what to do. Really, I think just to finish, we need to stop the stigma. Beware of making assumptions that a challenging family background must have caused the child's problems, because even if there are trauma-related problems, stay open-minded because you could also be missing an intellectual disability, ADHD, autism, or you could be missing post-traumatic stress disorder because that's another one that people miss, even though that is a trauma-related problem. So which came first, the chicken or the egg? This is a very silly graphic that I found on the web. Day one, God created the chicken. Whoosh! The chicken laid the egg on day 2. And then on day 3, man created the omelette. I don't actually believe any of that, of course, but let's embrace the chicken and the egg. So whether we call the problems experienced by an abused and neglected child in their family developmental trauma disorder, MAP, whatever, always think about neurodevelopment. Just assess for it, think about it. Think about prenatal toxins. Think about trauma and stress-related disorders like post-traumatic disorder, post-traumatic stress disorder, reactive attachment disorder, and keep an open mind. So avoid making an omelette. Don't mix it all together because you may never work out the ingredients. And the most important thing is we understand a child's making model so that we can be as helpful as possible. That's all I want to say, and I would love to hear your thoughts and comments. Hope nobody's having an omelette for lunch.
Thank you very much. So I'm just looking in the question and answers. There's none in there at the moment. So if anybody has,
have I stunned you all?
If anybody has any questions, then please feel free to post. Oh, there's one coming through now. Okay, Anita.
Hi, Anita.
Hello, Helen. Thank you. I think one of the most important things you raise is about, failing to treat where we do not treat because we think we know the cause. And And I thought it was a really interesting, there was a paper that came out in the Lancet that showed that even depression, which seemed to be attributable to maltreatment, still responded to the same treatments for depression that one would use. This was
if you've got the link, please put it in the chat.
Yeah.
I'd love to see that.
So I thought that was really interesting. And as far as I'm aware, I haven't seen any papers, but you will know this area much better than I. Has anyone ever shown, we see it clinically, of course, that, say, treatment of ADHD with medications is effective regardless of whether, what the putative cause is, whether, there's a background of maltreatment, whether there's prenatal exposure to something or another, because ultimately we're never treating cause, because most things in psychiatry, like general medicine, are multifactorial. You're seeing the clinical picture and then treating. So I think it would be really helpful for people to hear that.
Yes, I think I am not aware of such a study, and I kind of feel like I really ought to have done it, because I remember Eric Taylor, who, for those of you who don't know Eric Taylor, he really was, he was a real leader and still is in the field of ADHD. And many years ago, I asked him that exact question. He said, "Treat the symptoms." We don't know, and it doesn't matter. I have heard some adoptive parents saying that for their particular child, they've had stimulant medication. It hasn't worked that well. But then there are children who haven't been maltreated who have ADHD, and there's not a question about it, for whom stimulant medication doesn't work that well. So I think I always keep an open mind, because I, for a long time, thought that ADHD, for example, in institutionalized children, was caused by the extreme deprivation. I'm even not 100% convinced about that anymore, because I think there are kind of genetic confounds. People with ADHD may be more likely to abandon their children, for example. So you could just drive yourself mad trying to know what's the cause in abused and neglected children, and often their history is actually lost because nobody was paying attention. So as far as we know, you should. I think you should treat the symptoms regardless of the cause. But those studies do need to be done. There was a study by Rachel Hiller, beautiful study in JCPP a couple of years ago, about post-traumatic stress disorder and looked after and accommodated children. And she really went into the cognitive distortions. And they're exactly the same in complex PTSD as they are in the kind of PTSD that's caused by a bus crash, for example. So my gut feeling tells me just treat it anyway. But those studies do need to be done.
We do have another question now from Kerry Reid, and she says, fantastic, thank you. How can we make sure that neurodevelopmental services stop refusing assessment for looked after children and young people, as they often assume trauma, not ND conditions?
Yeah, I think the only thing I can suggest is, it sounds crazy, but send them that Dinkler paper. We were absolutely gobsmacked. I mean, I did not expect that answer, but that paper really does suggest that these are heritable problems that are not really anything to do with the trauma. And Andrea Donesi's group has done some really, and Louise Arsenault as well, they've done some really nice longitudinal studies looking at which came first in the lifespan. And there's really increasing evidence that children who experience abuse and neglect are more likely to have a more complex neurodevelopmental profile in the first place. So I think this is also true in CAMS. There are many, many CAMS teams across the country who are more likely to say, nah, that's social, that's not really psychiatry, if a child has a trauma history. And we have to stop doing that, because these children are our bread and butter. These are the children who are more likely than the rest of the kids on the CAMS waiting list to have ordinary, treatable psychiatric problems, things that we know how to treat. And it's pure discrimination if we don't see them. So I just think we have to keep saying that like a stuck record.
Do you think it is a big problem that people assessing young people in that way think it's either or, rather than you could have both together?
Yes, I think there's something about the human brain that does that. We like black and white. And I think it's really important to think about it both ways, because, so on the one hand, and I think this is true in adult psychiatry as well, if you've got a person of any age who's experienced horrendous abuse and neglect in childhood, they are more likely to have AN, other neurodevelopmental problem. So you need to check for it. But if you look at it the other way around as well, if you've got a child, and this is really common presentation, I mean, Rita would test, give you testimony of this. If you've got a child with ADHD and autism who is very, very hard to parent, then you need to be thinking about, is this parent well enough supported? Or is there a risk that this child could end up being abused and neglected? And I don't want to say that in a pejorative way of parents at all. We're doing a study at the moment, we're co-producing an intervention for parents with children who are involved in social work. And we've got this fantastic group of parent collaborators who've all experienced having a child involved in social work. And one of the mums, she herself has autism. Her daughter, she was a nurse. Her daughter has more severe autism. So she had to give up her job to look after her daughter, fell into poverty, and then was accused of neglecting her child because her child was their shoes had holes in them, and they came round on a Friday and there was no food in the fridge. It was the parents who hadn't been fed. I mean, we've got to try and understand how these things can be a vicious circle and try and get in early, give the support.
Just to say, Anita's put the link into of the Lancet Psychiatry paper into the chat, which sort of the summary was that contrary to previous studies, we found evidence that the symptoms of patients with major depressive disorder and childhood trauma significantly improve after pharmacological and psychotherapeutic treatments, notwithstanding their higher severity of depressive symptoms. So that is interesting. And Katrin, I think, has shared that with everybody now.
That's great. Thanks a lot. Are there any other questions just now? If there are no new ones, I was going to tell you the hilarious. I was supposed to present this Dinkler paper, the one about the behavioural genetics study at 5 o'clock at a conference, and I thought, I'm not going to be able to get this across, so I need an anecdote. I need to get across a nightmarish child, and I thought the only nightmarish child that I can talk about non-judgmentally is myself. I was the worst child ever from all accounts. My parents used to laugh about it, when they were with their friends, that I would just keep them up all night. And so eventually, back in the 70s, they got me, back in the 60s actually, they got me prescribed sodium amytal, which is like a horse tranquilizer. And they went to pick up this prescription. And the pharmacist said, "You can't give this to an 18-month-old. This is an adult dose." And they said, phone the doctor. And they could hear both sides of the conversation behind the counter. And the doctor said, the pharmacist said, "You can't give this. This is an 18-month-old. This is a baby. That's an adult dose." And the doctor said, "You, this baby." So eventually my parents took the sodium amytal so that they could sleep. But I just think that's a beautiful example of how difficult some children can be. And if they've got a supportive GP, you're up to maybe test a psychiatry.
Oh, no, that's a great anecdote. I've noticed there's one more question in the box, which is quite wordy, but I'll read it. I don't know if you can see it as well.
I can read it. Is it from Esther?
Yes.
Yeah, so I assume that the profile for an ND plus trauma is not something different, just a mixture of symptoms of both. This was quite eye-opening, and I agree it's crucial the open mind. The second question, what about when the profile is more behaviour and not inattention and hyperactivity? Or if ADHD symptoms are only reported at home as if they were masking, but school reports are totally reassuring. I had this in MAP, stroke, ACEs and FASD. Really great questions. So I think the first question links to the second, Esther. So in answer to the first one, I do think there are ways in which presentation can be a little bit different, but it is in many ways simply a mixture. So if you think of a child with ADHD who hasn't got any experience of trauma, who is hyperactive and makes a lot of mistakes. I mean, any of you who are parents of children with ADHD will know that one of the things that gets harder and harder as they get older into their teens is that they muck up. They double book their friends, they forget their homework, and they feel like an idiot. And it's really helpful when they realise they have ADHD and that they can explain, "Look, I'm really sorry, I just dropped my balls." And they will ask for help, and they can get help with that. The problem is if you also have reactive attachment disorder where you don't seek and accept comfort, then you won't accept help. And so the ADHD becomes much, much harder for the child to manage. and for the parent to manage. So it really is just a mixture of the symptoms, but the manifestation means that it's hugely more burdensome for parents or adoptive parents or foster carers, because you could help that child. You could help them organise their school bag. You could help them do their homework, but they won't let you. They're not even going to ask, and they're going to push you away if you try. So I think when you talk about masking, that is often particularly, I think it's true of many children with neurodevelopmental conditions who haven't had a history of maltreatment. My little patient Aidan, for example, he hadn't been maltreated at all, but he very quickly suppressed his tics at school, and that's one of the ways that we were able to diagnose that this was tics and not just a stereotypy that was going to disappear. But that's likely to be a much bigger problem if, again, you don't seek help. So if you're a child who sits at the back of the class while your emotions start to come to the boil, and then, or if you're a child who masks until you get home, and then it all kind of comes out with the adoptive parents or the foster carers or birth parents are trying to get things back on track. I think that's often an even bigger problem for children who've got that problem with seeking and accepting comfort.
There's one more question come in from Reese, and he says, excellent talk, Helen. I wondered whether there were key considerations when co-producing or implementing interventions with the
That's a great question. Yeah. People often worry about stigma, and they worry about, gosh, are you labeling and all that. So it's been such a learning experience working with parents these are parents of young children, so we're not co-producing this intervention with children, but we actually are co-producing another intervention with adolescents. But anyway, the parent one first. We were really interested to know whether parents who themselves had children, either in the care, some of them in the care system, or just involved with social work, would feel stigma if we started talking about things like autism, ADHD, and PTSD and reactive attachment disorder. Not at all. In fact, I just was amazed at how much this group of parents, these two groups of parents actually, but one in London, one in Glasgow, have really, really understood this whole vicious cycle that can happen if you're bringing up a child with a neurodevelopmental condition. You've maybe got neurodevelopmental condition or symptoms yourself. So, for example, you may have ADHD and keep getting sanctioned by the benefit system because you miss your appointments, or you're getting very anxious as a parent because you need routine and your child is not giving you routine. They really, really got that, and they really wanted earlier help with that before things start to actually fray at the edges. We're doing a study of dyadic developmental psychotherapy, a trial of dyadic developmental psychotherapy, which is a psychotherapeutic intervention for children with what we've been calling maltreatment-associated psychiatric problems. And we've got a really interesting youth advisory group who are all young people who were either in the care system or adopted under the age of 5. They're all in their early 20s. And again, they don't seem to see this as a problem at all. I think they really like the idea of children and parents being really carefully thought about in terms of their whole profile in a respectful way. This is your make and model, and it's going to have strengths, difficulties, so that you can try and understand how your make and model interacts with your parents or with your adoptive parent or your foster carer. I think the key thing is to do with respect.
Okay, thank you. And I think there's sort of one last, seems to be more of a comment, which says we need schools to acknowledge that trauma is relative and that children with ADHD and ASD struggle more with less stress, and to stop punishing dysregulation.
Yeah. I've used the term the zone of tolerance. It's a term actually the Scottish Government uses in their kind of trauma aware policies, and I love that idea. When I was at medical school, we were taught about it in terms of the Yertz-Dodson curve, which is where when you're asleep, you're not performing. So you've got to get alert. And then all of us get to an ideal zone when we're most alert, but we're not overstimulated. Once you're overstimulated, you all know that feeling. You get too many things going on, too many tabs open, or you're too anxious and your performance falls. What I always say is that children with neurodevelopmental conditions, they've got a narrower zone of tolerance. Or children who've got post-traumatic stress disorder or reactive attachment disorder, they've got a narrower zone of tolerance, but they've still got a zone of tolerance. But we need to do more as adults to help them not fall out of their zone of tolerance. And I think you're absolutely right. There just needs to be more understanding that there are things that we can do. The classroom might be too noisy at that moment. That child might need to take themselves out into a quieter setting. They might need to be able to see the door if they're very jumpy about new people. I think there's probably a lot of ways in which we in CAMS could work with teachers to help them think about individual children in those simple ways that could help with that.
Thank you. Yeah, I think we're coming to 3 o'clock now, and I think that's the questions and comments done. So thank you so much once again for coming to talk to us. It was so interesting. And thanks to everyone for attending.